Hello, my name is Colleen Curtin. I'm a third-year medical student at University at Buffalo. I am currently in the diagnostic imaging for primary care physicians course through the family med department, and this is my case presentation. This is a 64-year-old African American gentleman who was in a motor vehicle accident 1 month prior to examination. He was waiting the left-hand turn lane when he was struck from behind by another vehicle. He described that he hit his chest on the steering wheel, but his airbag was not deployed. The patient was wearing a seatbelt during this accident. He described feeling immediate chest pain, neck pain, and shoulder pain, but he denies any loss of consciousness or blood loss. He was taken to the emergency room where he was examined, and they took radiographs and ultrasound at this time. Ibuprofen was prescribed for pain. Since the time of the accident, the patient complains of having continued chest pain. He describes the pain as being on his left side, spanning from his left mid-clavicular line laterally into his shoulder and upper back. He describes the pain as a continuous and sharp pain, as if he is being stabbed, that's usually brought on by movement. He describes a few incidences of feeling pressure, painful pressure, usually when he is trying to move or bend. He said that the pain is made worse by movement and deep breathing and is improved by prescription medications such as hydrocodone, lying on his back or on his right side. He describes that he's been sleeping in a recliner to avoid the pain that he feels on the left side of his chest. He describes that the pain feels worse first thing in the morning and currently rates the pain as 4 or 5 out of 10, but says that at its worst it can reach a 7 out of 10 daily. He's been working as a machinist for 11 years and has not been able to work since his accident. He denies any headaches, any loss of bowel or bladder control, but since the accident, he has had some loss of appetite, anxiety, and sleep loss. He mentions some numbness and tingling in his left arm. So his past medical history is significant for hypertension, hypercholesterolemia, alcohol abuse, and a 1 year history of pinched nerve in his neck that causes occasional shooting shoulder pain, as well as a 3 year history of acid reflux. He takes amlodipine, benzaprine, low-dose aspirin, and multiple vitamins. He has had surgery in the past for a stab wound to the chest and for a hernia repair. His family history is only significant for alcoholism and cirrhosis, hypertension, and diabetes. So in physical examination, we saw a 6'2" male who weighs about 200 pounds. His BMI is 25.7. His blood pressure in the left arm in the seated position was 110 over 90 milligrams of mercury. His head and neck exam was normal, as well as his chest exam. His heart was of normal rate and rhythm. His lungs were clear to auscultation bilaterally. His musculoskeletal exam was more significant. He did not appear to have any visible deformities of limbs, abdomen, or chest. On palpation, there was no reproduction of pain in the left or right shoulder. Pain was reproduced when we were palpating his left lateral and dorsal ribs, however. The patient demonstrated generalized decreased range of motion in the cervical spine with flexion, left rotation, and left lateral bending, producing pain to the left shoulder. Cervical compression testing also produced pain extending into his left shoulder. The range of motion in his right shoulder was normal, but the range of motion in his left shoulder was decreased. He could only elevate his shoulder to 90 degrees, which caused pain. NIRS testing, Hawkins-Kennedy procedure, and supraspinatus procedure were all positive on the left side, but not on the right. Our neurologic testing revealed decreased biceps tendons reflexes on the left side, as well as decreased supraspinatus strength on the left side. However, the right side had normal strength and reflexes all around. Straight leg testing did not elicit pain. Gait was normal, and cerebellar function was intact. So now we're going to look at some of the imaging that was done on this patient. First, we see here that he has a PA chest x-ray. So what you see here is that there's a fracture of the third rib, and then there's minimal blunting of the costophrenic angle down here on the left side. There's some nodular opacities in the upper right lung, and you can see there's evidence of a prior sternotomy with the clips in here, and then clips in his aorta indicating previous procedures. You can notice that despite the trauma, he doesn't have any pneumothorax around the edges here, and that's despite probably multiple rib fractures and the history of traumatic injury. So looking next, This is a lateral view of his chest x-ray. Again, you can see the evidence of prior sternotomy and you can see the clips in his aorta. It's hard to visualize the borders of the heart here. And then you can see the tortuous course of his aorta as it descends in his chest. So our next image is part of his rib series. So in this image, it's really optimized for looking at the bones, and you can see this fracture here in the third rib. The cortex do not line up, and you can see a very clear fracture. Um, However, the other ribs, it's harder to appreciate any issues. So going on to our next film, it's the next in the rib series. It's a more oblique view. And again, you can see very well that fracture in the third rib. And when you come down, you can see fractures in the 8th and 9th ribs. So counting, you've got 3rd, 4th, 5th, 6th, 7th, and then so 8th, you can see the fracture here, and 9th, you can see the fracture here. So you see 2 fractures there, but no other fractures are seen at this time. Finally, at this last one, we're looking at the lowest ribs in his rib series here. Kind of questionable to see if there's any other fractures in here. And you can't quite see the 8th and 9th rib fractures as we had seen before. So we got a CT of the chest to further evaluate his rib injuries. So if you look at this level here, we're at the level of the third rib, which we had seen previously. So again, you see this fracture. You can see it in the axial view, and you can see it very well in this coronal view as well. And continuing downwards, at the level of the 5th rib, again, you can see the fracture in the rib here. And when you look across into the sagittal view, you can see that the bone is not quite lining up. The cortex isn't in a straight figure, indicating that there is a fracture here. Continuing downwards, you can see here we're at the level of the 6th rib, and you can see that there's a fracture laterally in the 6th rib that we did not visualize before on the bone scan, or the rib series. And then again, you can see in the sagittal view right here just the discontinuity of the ribs in this plane, indicating fracture. Continuing onwards, this is at the level of the 7th rib, so we see the fracture here. You can see the cortex isn't uniform, and here you can kind of see again where the fracture would be in the sagittal view. And then this is the level of the 8th and 9th ribs, so here you see the fractures on the axial view, and you can see them as well a little bit more subtly, a little harder to appreciate on the sagittal view. So while we were doing the CT for his rib evaluations and evaluations of just any general chest injuries, seeing as he has so many rib fractures, we noticed a few other things. So here you can see a hiatal hernia is visualized. You see the diaphragm coming across here, and coming above the diaphragm, you see that some of the stomach is above this level, which indicates a sliding hiatal hernia. You can see it on this as well in the different window. And you can also appreciate at this view the fracture of the 6th rib in the bone window. Continuing onward in the axial view, you can see that there is an aneurysm in the ascending thoracic aorta. So you can see it's a fusiform aneurysm, meaning that the layers of the aorta are kind of all dilated together. There's no saccular outpouching or intimal flaps, so this is probably a true aneurysm. We measured it around 4.87 centimeters, which is consistent with a true aneurysm. So we don't see any outpouching, any intimal flaps, or any intraluminal mural thrombi, which would be consistent with a traumatic injury due to deceleration, such as motor vehicle accident, like a pseudoaneurysm or tear. So you can also see it in the sagittal view, just how wide the aorta is as it's ascending. And finally, it's interesting to note that despite all of these rib injuries, significant traumatic injury, his thoracic spine shows no disc bulging or herniation, no nerve impingement or spinal stenosis is seen. You can see that the spinal canal here is very patent all around. There's no impingement at all from any discs. So our differential diagnosis for these findings, given this patient's recent history of motor vehicle accident, we need to consider traumatic injury to the ribs, chest, and spine, which can include fracture, contusion, sprains. Given his age, there may be elements of degenerative disc disease, spinal stenosis, or cervical disc herniation, which need to be ruled out, which we can see in the thoracic MRI previously that there is none of that. That would be significantly impairing his function. The findings of aortic aneurysm and hiatal hernia on CT are likely not caused by trauma. However, chronic hypertension, age, and previous injury to the aorta put this patient at risk for aneurysmal dilation to the aorta. Traumatic injuries such as transection, aneurysmal hematoma, or pseudoaneurysm may be ruled out by CT testing. The hiatal hernia that we saw is also likely an incidental finding, especially given the patient's history of acid reflux for 3 years. Loss of elasticity and muscle weakening due to normal aging and male gender put this patient at risk for hiatal hernia. In addition, up to 60% of individuals over the years of 60 have hiatal hernias. So it is very common in patients of this demographic to see issues here. So our diagnosis for this patient is rib fractures. He has a posterior fracture at the left third rib, and he has lateral fractures on ribs 5 through 9. We also noted during his workup that he had an ascending thoracic aortic aneurysm and a sliding hiatal hernia. So we confirmed these diagnoses with the CT evaluation that I've just shown you. So for treatment and follow-up, conservative treatment of rib fractures include pain management as well as incentive spirometry to prevent complications such as atelectasis. Shoulder injuries, as indicated by the physical exam findings, will be further evaluated with MRI and plain films. He did have a decreased range of motion and pain on range of motion, so we'll do MRI and plain films of the shoulder, especially around that acromioclavicular joint. In addition, the cervical spine will be examined through MRI to look for evidence of nerve root impingement that may be causing numbness and tingling in the arms, as he complained in his history. So this patient has been following with this chiropractor, receiving ultrasound therapy to the lower cervical region, as well as getting chiropractic adjustments. Regarding his aortic aneurysm, the patient should probably continue to see his primary care provider for blood pressure control, as this will help prevent further dilation of the aorta. And monitoring may be suggesting, so you can use MRI to evaluate changes in the diameter over time. We did consult that he see a thoracic surgeon, though at this point, open or endovascular surgical correction is not suggested for ascending aortic aneurysms that are under 5.5 centimeters in diameter. So at 4.87, this patient's diameter isn't quite as large as needed for indication that surgery may be necessary. Treatment of hiatal hernia is dependent on the patient's symptoms, so patients with no symptoms of reflux are usually not advised to have surgery. However, patients with sliding hiatal hernias with gastroesophageal reflux disease, such as this patient, are indicated for surgical correction of the hernia with fundoplication. So just kind of discussing the case a little bit, this patient's rib injuries prompted him to receive further imaging that revealed an aortic aneurysm and hiatal hernia on CT scanning. But these injuries are likely, while these injuries are not commonly linked with trauma, they're likely incidental findings which can now be addressed and followed. So a hiatal hernia occurs when abdominal contents protrude above the level of the esophageal hiatus in the diaphragm. So right here, you can see there's two types of hiatal hernias. The more common type is a sliding hiatal hernia, and this occurs when the gastroesophageal junction is placed above the diaphragm, as we see here. This type of hernia is what we see. The second and less common type of hiatal hernia is a paraesophageal or rolling hiatal hernia, where the gastroesophageal junction remains in its normal location below the diaphragm, but another portion of the stomach bulges up next to the esophagus through the esophageal hiatus. So it is suggested that 5 to 10% of hiatal hernias may be caused as a result of trauma or injury, but however, most frequently, traumatic accidents that injure the diaphragm result in traumatic diaphragmatic hernias, where abdominal contents protrude through the left hemidiaphragm. over here because it's not protected by the liver as the right side is. So you see protrusion of bowel contents up into the thorax there. The esophageal hiatus is the most vulnerable opening in the diaphragm, as it is the only opening that connects the thoracic and abdominal compartments directly. In addition, because the esophagus needs to expand to allow food to come down, it doesn't fill the opening completely of this hiatus. So there's a little extra wiggle room for things to slide upwards, for the stomach to slide upwards. So this allows the gastroesophageal junction or parts of the stomach to pass through the hiatus in the diaphragm. Hiatal hernias may also occur due to congenital weakness or abnormalities in the hiatus, and these are sometimes caused by persistent and intense abdominal pressure, such as chronic coughing, repetitive vomiting, straining to pass bowel movements, or lifting weights. So certain conditions may predispose a patient towards the development of a hiatal hernia, which includes muscle weakening and loss of elasticity as part of normal aging. In addition, conditions that increase intra-abdominal pressure, such as pregnancy, obesity, or abdominal ascites, um, may increase a patient's risk for developing hernia. There's also some suggestion that a hiatal hernia is more common in men than in women. So most patients with hiatal hernias are asymptomatic. However, an individual may be predisposed to reflux or have worsened gastric reflux symptoms after herniation occurs. The patient may describe an acidic or sour taste in their mouth or complain of increased belching, difficulty swallowing, heartburn. In some cases, patients may have complications due to hernia, which could include intermittent bleeding from ulcers associated with esophagitis, erosions, or ulcers, and this bleeding can cause anemia. So this is rare, however, it does happen. In addition, a paraesophageal hernia, where the hernia may incarcerate the part of the stomach bulging above next to the esophagus, that can incarcerate, and that's a very rare occurrence. So treatment of sliding hiatal hernias such as this one should be correlated with symptoms, as previously mentioned. If the patient is having symptoms such as gastroesophageal reflux disease, surgical correction of the hernia with fundoplication is suggested. And then continuing onwards, an ascending thoracic aortic aneurysm, it is another important finding that was noted on this patient's imaging. Thoracic aortic aneurysm is defined as a dilation of the thoracic aorta greater than 4 centimeters at any portion. And in the thoracic aorta, this occurs most commonly in the ascending part of the aorta. So true aneurysms occur when all 3 layers of the aorta, tunica intima, tunica media, and tunica externa, are all dilated. So morphologically, true aneurysms have a fusiform shape, meaning that there is uniform and symmetrical dilation of the entire circumference of the aortic wall. Thoracic aneurysms can be further classified by which region is dilated, either the ascending aortic, the descending aortic, and aortic arch. So ascending aortic aneurysms occur between the aortic annulus and the more distal innominate artery. Descending aortic aneurysms occur distal to the left subclavian artery. So the tensile strength of the aorta is mostly contained in this medial layer. So structural proteins such as collagen and elastin are most essential to this function. So diseases that may disrupt these proteins, such as Marfan's disease or Ehlers-Danlos disease, increase the risk of aneurysm. There's other diseases that could increase the risk of aneurysm, including Loeys-Dietz syndrome, late-stage syphilis, Takayasu disease, and rheumatoid arthritis. In addition, hemodynamic factors are involved with the formation of aortic aneurysms, and this is best explained by Laplace's law. So this law explains that in the arterial wall tension is proportional to the pressure times the radius of the artery. So increased pressure, such as those found in systemic hypertension, increases the wall tension and aggravates the aneurysm, making it larger, increasing the radius. And so then once the radius is increased, this acts to increase wall tension, kind of feeding back into that loop and increases the risk of rupture or dissection. Thoracic aortic aneurysms are typically asymptomatic and are frequently found on imaging for other causes. When they do present, symptoms include intrascapular back pain or central chest pain. In addition, if they compress the esophagus, it may cause dysphagia and weight loss if it reaches that size. And aneurysms in the ascending aorta may also compress the trachea and descending airways, causing difficulty breathing. So in patients with mild to moderate dilation of the aorta, under 5.5 centimeters in the ascending aorta, it is appropriate to manage aneurysms medically with blood pressure medications such as beta blockers. Controlling blood pressure helps prevent further dilation of the aorta. In the case of severe dilatation of the aorta, greater than 5.5 centimeters in the ascending aorta, they suggest that surgical intervention may be applied in these cases. Repair may involve an open thoracic surgery or endovascular repair, and these have similar success rates. As opposed to true aneurysms, where all three layers of the aortic wall are dilated, pseudoaneurysms or false aneurysms and transections of the aorta commonly occur during traumatic injury with blunt trauma to the chest. So a pseudoaneurysm is a dilatation of the aorta where there's a focal outpouching of the aortic wall, usually due to deficiency in the tunica media or intima, the inner two layers of the aortic wall, and less commonly due to weakness in the outer layer, the adventitia. These aneurysms tend to have a saccular shape with localized outpouching, and traumatic injuries such as transection, which usually present with rapid onset hemodynamic instability, retrosternal chest pain, and referred interscapular pain, dyspnea, hoarseness, and cough. These symptoms are thought to be increased or caused by increased mediastinal pressure and stretching of the structures in the mediastinum, and survival rates of traumatic aortic injuries such as pseudoaneurysm or transection, dissection after a vehicular accident are low, with mortality rates estimated between 80 and 90%. So that concludes my discussion for this case. I hope you have enjoyed it and learned something. Thank you.